Alrighty, took off the chest heart rate monitor from Power Labs, and then I looked at the analytics of our workout. It was not that difficult, but it was hot and I got sweaty. So you're moving, you're working your core. Every time you do hip flexion and you're doing your ducks, your leans, you're working your core. That's making you sweat. And so also with the movement of your upper body and breathing, you're getting your heart rate up, which is wonderful. Helps burn off any excess cholesterol, get your toxins in your body heated up so you don't really suffer from them. Any antigens, usually they get denatured. You don't want to get too hot, so you do have to hydrate. I drink 1 full bottle of water. Why don't we just do some massage today? I didn't really have anything come up on health to look up in the Merck manual. So today we'll go ahead and we'll let's look at my heart rate monitor first. My heart rate. So this workout, it was the usual boxing. We're just doing this three times a week. You can squeeze it in. It's really not that difficult. You need a bob to have the higher intensity to get your heart rate because you need that force pushing back against you. Otherwise, you could still get a sweat on just doing it with that because those gloves are 16 ounces, which is like 1 pound each. It's like holding 1 pound things. If you don't have gloves and you're going to do it by yourself, use the 1 pound weights. 1 pound weights. There you go. You're in your office. Get up and move. You're getting too stiff everywhere. Your joints are getting stiff. That's a good exercise to do. It's fun. Makes you feel empowered. Get you all psyched up before you have to do something. And it's like meditation, really. And then you don't have to listen to me or anyone else. You can go at your own pace. Okay. So on that app, here's what we have. For the history, I don't know why it wasn't letting me record it. I seriously retyped everything. I had to type that in. 138 beats per minute was the average heart rate. 195 calories burned. I just put in there the description right there. Outdoors, 87 and 90 degrees Fahrenheit, 5 3-minute rounds. We had 30-second rest breaks. Now we're going to go up here. Come on. Which way? Here we go. And you can look and see. All right. I don't need to look up anyone's background to know they're fucking weird. Okay. That's something bigots do. Okay. A lot of bigots. People trained to be bigots, trained by bigots, don't know they're bigots, or fucking bigots. They don't know a cunt when they see one and not to trust a cunt, so they have to look them up to see if they can mess with that cunt and possibly punch that cunt in the face. And you know what? I don't need a background check to tell me if a person's a fucking cunt or a weirdo. Okay. I'm not going to pop someone in the face and look at their record and see if they need to be popped in the face because I know my rights. And if someone violates them, I say, can I get away with punching this cunt in the face? Maybe. But no, I can't because actually I can't get in trouble anymore. But if someone provokes me and I feel threatened, I will fucking fuck shit up, okay? I don't fucking care. I won't kill anyone unless they kill my dogs or people I love. And you can see my heart rate over the 20 minutes going up. You can see the little dips with each little rest. And then, it's hard to do it when I'm moving. Right there. 1, 2. So, 1, 2, 3, 4 dips between each round. Those were our rest intervals. And then round was the more difficult. Looks like the second round was because it has a higher slope. And then a little bit more towards the last one. That would be the second best one. And then the second to the last round, right here. And then the third round. First round, just warming up. Not really that bad. Nothing really going on there. Just getting our heart rate going. All right. So now I'm going to go ahead and take my blood pressure. We have been away from the boxing bags for about 10 minutes now. It's all slowed up. I'll disinfect that chest strap before I put it back. And then we're going to take out the scrapers, the instrument-assisted soft tissue mobilization tools, and then we're going to scrape our forearms. We're going to look at our grip strength, too, after the boxing, or after we do our blood pressure. I'm going to do the right arm first. I'll hold it right here. And we're just going to wait. I'm just going to look at this the whole time. Make sure your legs are uncrossed too. Okay, so 112 over 74, 82 beats per minute. I'll write that down. Post-workout. The right blood pressure was 112 over 74, 82 beats per minute. And the left. All right. Now we'll go ahead and do the left one and turn it off and on again. We're not going to do anything. Don't cross your feet. Oh, yeah. Okay. Okay, now I'll turn it back on. Just breathe normally. Ninety-two over 66, 83 beats per minute. Okay, and we'll turn that off. Let's go ahead and get a Clorox wipe and wipe off the chest strap. We'll play the other parts of the playlist later on, so you don't get tired of the same songs. I can't guarantee I'm going to tell you what to do or not. You should really just do your own stuff. As long as you're moving around, you're doing good. Great job. And I just hook it into my blood pressure cufflink now. And I take it with me everywhere I go. Because I have a gym membership at 2 places not that far from each other. Okay. So now we're going to do our grip strength. I'm going to turn it on. And I'm going to start it. .0. Man, that's weaker than grip. 67.0 on the right. That's weaker than before. I've got some stuff going on. Now we're going to go to the other one, the left. 64.0. Ooh, weaker after boxing. Okay, all that. We're going to have to do some scraping. Let's do some scraping. Turning this off. Hold on. Do I just turn it once? No, okay. Now I want to turn it off. There we go. So I'm going to take out the instrument-assisted soft tissue mobilization tool. And we are going to scrape my forearms. And then we're going to check the grip strength afterwards. It should be better because, you know, I did massages earlier, and then doing that, it's natural to get some inflammation in there. A little bit of settling down of fibroblasts, connective tissue. I'm just getting my insurance assisted. Oh, here it is. It's actually already out. So we'll just do this a couple minutes. You don't really need lotion. I'm the only one who uses these, so I don't even really need to disinfect. But I will because I have a Kleenex right behind it. So let's come up on it. This one actually is pretty nice. As well as, I think this one might have had some use too. And then we'll go ahead and take this one too. Now these are actual IASTM instrument assisted soft tissue mobilizations. They may look like sharp little objects. They're also called gua sha if you have those ones available. But these are beveled. They're a specific bevel so that they don't cut you and they get through that connective tissue of your tendon, myofascial, ligamentous tissue so that you can get more neurovascular circulation and movement from your muscles, break up adhesion lesions, scar tissue. And we're just going to scrape our forearm. You gotta force yourself to do it. If you don't, you can get someone else to do it. We're just gonna go down. I'm on the pinky side, so I'm just taking it from right here on the edge. Kind of like you can go soft, you can go little, you can go right around there, right around the arteries. Should be the ulnar artery on the pinky side. Going into your forearm flexors, going to the olecranon process of the elbow. You're just scraping in a straight line, going through all those layers of tissue. You got your flexor digitorum brevis longus, flexor digitorum brevis longus, flexor pollicus. And then on the other side, you have your extensor on the thumb side. Now we're going to go from the thumb. It's the outside of your forearm. We're scraping, we're filling little speed bumps. We can just scrape slowly, getting along those muscles. Make sure you're on muscle and connective tissue, not the bone. You don't want to bruise their periosteal lining of their bone. We're just going to keep scraping. And we'll be scraping to about the cubital fossa, going on the outside. Really feeling some relief in here as we get in there. You know, last time I did this, I was a little sore. I didn't drink enough water. So do make sure you stay hydrated. And then we're also going to stretch our forearms too. See how better our grip strength is. And just keep alternating. Just keep working your way with it. I can also show you the app. Let's go to the app real quick. I'll go ahead and share my screen. And then we'll go ahead and I don't think I logged in for like a week and a half. So I'm going to drink some water right now. Sometimes it makes me sign in again when I stay off of it for too long. All right. Now we're going to go ahead and let's look at it. See if you guys can do this. Yes, you can. We're going to go over here to the forearms. So then we're just going to add some connective tissue. So you can see the deep fascia lining. Here, it doesn't matter that it's pretty much the same for the male or the female. If you want, we could go to the actual upper limb. So we can just zoom in on it. And you can see this fascia where it can hold some, covers the muscles and protects them, but it can also hold fluid or have its own injuries and cause scar tissue between layers. Let's add the muscle layers. Also, when we get into the hands, in there, the ligaments, tendinous, synovial fluid, all those bursas. Okay, so we're going to add some musculature. Let's keep adding musculature. And just look layer by layer as we're adding those muscles, what we're massaging. Okay, if I click on it, you won't see it because of all the connective tissue that's already there. Adding another layer, another layer, another layer. It's like there's 4 layers of muscles we're getting through. So you're going to go on the radial side, that's the thumb side, or the radius bone, and then the pinky side, right here, that's the ulnar nerve side. We'll go ahead and add the arteries. And then look at where they are as we remove the connective, the muscles. Look at the top layer, doesn't really touch on much. We'll add some more muscle layers over it. You can see about the 3rd layer, they start covering. And then it's like 5 layers right there. All right, so we'll be focusing on all those muscles. Okay, all right. And then when you're into the hand, look at where the muscles are. Right in here, right on the thumb, the pinky, right in between, right in there. Okay, everything else is the blood supply, not really very many muscles. Okay, let's remove some of that connective tissue and just leave the muscles, and you can see not really any muscles in the actual phalanges, are there? Okay, so these are all the muscles right here in your metatarsals, the palms of your hands, and then also into the thumb and the pinky right there, just at the base, right there. All right, so we'll be massaging these muscles. I'll just leave it on the screen, and then we'll go into here, and I'll just make sure I'm showing you the right stuff. Or actually, maybe I could just split screen this, and then you can look at anatomy with me as we keeps doing that. Weird. What is it doing? It's saying, oh no, you're not gonna do that. Okay, so we're just going to stay here and just look at this, and we'll be scraping as we go. Just make sure you guys can see this. Scrape. Getting up blood flow, breaking up adhesion lesions, getting that beveled edge. Okay. Getting it close to the tendinous attachment, right at the back of the elbow, inside of the forearm right here. Making sure we have that neurovascular supply freed up to give us the strength we need. If not, we have to go up higher the chain. Could be in the shoulder, pecs, right at the base right here. Okay, let's go ahead and work on the other arm, just like a few minutes each side. Some people do it like 10 minutes. We'll see what it takes us. It's not meant to bruise. So it's just going layer by layer through you can actually even flex if you want. do an MRT, muscle release technique. Contracted and elongated state. Contracted for the extensors, elongated for extensor. Okay, elongated for the flexors, and then contracted for the flexors. Contracted, elongated. All right, let's use another one. And then we'll just enlarge this, and we'll stop because we don't need to see all that, do we? You just had to go look, didn't you? Okay, interesting. Well, shoot me an email if you want to be looking at that anatomy up the whole time, because I don't really know that you guys have a good view of what we're doing. And this is really great because it's taking right along the long bone, all that muscle, and it's just pushing it away without bruising. Generally just to go towards the heart, but whatever works. See, for adhesion lesion, that's why they have cross fiber friction. Okay, and we are doing instrument-assisted soft tissue mobilization. So, working on that soft tissue between all the layers, freeing up some movement, freeing up vascular supply to your muscles, neurovascular supply to your hands. Not trying to bruise. Okay, well, getting a hand cramp there. Remember, our muscles go into the palms and stop at the phalanges, okay? Only the thumb and the pinky had that musculature right there. And this is actually really nice. Scraping it away, getting some extra movement in the hands, freeing up any adhesion lesions. Let's go ahead and do it on this one too. Just have my hand flat on the table, just scraping towards the heart. It's that beveled edge. It's like circular, hollowed out circular edge. Okay. Getting some redness means that it's working, getting that vascular nutrient supply in and the venous supply to empty out waste material. Lymphatics flow with the blood supply as they move and as your muscles move, so it's pumping out antibodies to help, and macrophages to phagocytose all of those particles that we're scraping off into tinier particles so we can uptake it and push it through your circulatory system, dumps it at the thoracic duct, right here on your left side of your body, into the subclavian or brachiocephalic artery, depending on how your body is, and into the right atria of the heart, where it pumps out, gets cleaned in your pulmonary veins. Oh, veins leaving the body? Yes, leaving the heart. The pulmonary veins. And then back again after cleaning, exchanging for oxygen, carbon dioxide waste. See that redness? I don't know if you can see it because the light's shining on it. There's a little redness. I see it. I don't think you see it. A little bit. All right. All right. And then we can even use the other edge, the straight edge. Getting in there, scraping it out. You can use that edge. Just lightly, do your own tolerance. You can do it faster if you want, more vigorously. Get some more circulation in there, nutrient supply to and from that region, helping to detox, eliminate scar tissue. Takes the weirdo to know when, and I'm not when. Sucker. Another weirdo walking by. It's always a dude. It's always a dude. It's a fucking weirdo. Oh. Alrighty. breaking up those adhesion lesions. And then we're just going to chest out. Let's go ahead and work this side too of our palms. Really getting a tingly sensation from not having as much vascular supply. Now we're getting a more rich supply of it. Circulation. Just digging in there gently, scraping it to your tolerance. All right. Now let's look at our grip strength. I'm going to turn this on. Wait till it says my age. Start it and zero it out. 76.6. Oh, okay, yeah. So that's better because originally before the workout it was 69.4. After the workout, 67. And then after scraping, 76.6. Awesome. See the left. $70.2 left. 70.2 pounds. Much better. Got that nutrient supply in there. After the boxing workout, the left was 64.0. Before the boxing workout, it was 65.6. After scraping and the boxing, 70.2. So we warmed it up. And then we took away all the extra adhesion, some of it, not all of it. And I'm going to turn this on. Okay. That's it. That's it for today. All right. Well, you guys have a great rest of your day. If anything pops up, we'll talk about it. Nothing really popped up right now, except for trigger finger. Let's just look at trigger finger. We can do that. We can read it from the manual. But let's disinfect these first with our remaining Clorox solution off of our Clorox wipe we used to wipe our chest strap, our heart rate monitor chest strap. And I'm going to put these back in their case. All right, cool. I'll put this up. I'll just do this regularly. I'll prevent any types of scar tissue from impacting our strength and health. All right. Now we're going to get the Merck manual. We're going to look up trigger finger. You saw that there weren't any muscles. You saw there's a lot of connective tissue in the hands and forearms, but mostly the hands. So now we're going to look up trigger finger. And we'll just see what it says. But it's actually whenever the finger gets stuck. It's usually an extension and you have to pull it back into flexion. And one lady said she was actually having weakness with her extension finger. She couldn't pull the light cord off, and she does have osteoarthritis. She had a surgery for that. For the wrist, actually. They took out a carpal, actually, from her wrist. They took it out of another person's wrist, too. But I didn't know they took it out of hers, too. She couldn't remember which one, but I could palpate that it did seem like there was something missing around where her lunate and I believe it's the capitate? No. Lunate starts with a C. I believe it's the capitate. I think it's the capitate. Yeah. So I'm just looking at trigger finger. Trigger finger 271, 289. 271, 289. All right, trigger finger. Tendinitis and tenosynovitis. Let's see where it says trigger finger. Yeah. The other one was tenosynovitis. Tendinopathy. Okay, so trigger finger 271, 289, did it say? digital dequivans. Okay. Digital flexor tendonitis and tenosynovitis. Trigger finger in parentheses. Okay. So, trigger finger, digital flexor tendonitis of those tendons. You saw that the muscles that have attachments, tendinous attachments, the muscles end at the phalanges right here. So the tendinous attachments would have to be here, and then the muscles going across those metacarpals. Digital flexor tendonitis and tenosynovitis are inflammation, sometimes with subsequent fibrosis of tendons and tendon sheaths of the digits. These conditions are idiopathic, which means unknown, but are common among patients with rheumatoid arthritis or diabetes mellitus. Repetitive use, which is basically just diabetes, type 2 diabetes, that's the one they know of. Type 1, they usually just say type 1 diabetes. Repetitive use of hands, as may occur when using heavy gardening shears, may contribute, like because you're constantly having to use your forearm flexors and your wrist flexors. And they see it in the elderly. In diabetes, they often coexist with carpal tunnel syndrome and occasionally with fibrosis of the palmar fascia. Pathologic changes begin with a thickening or nodule within the tendon. When located at the site of the tight first annular pulley, first digit is the thumb, the thickening or nodule blocks smooth extension or flexion of the finger. The finger may lock in flexion or trigger. So this is the trigger. It locks in flexion. And they can't get it into extension like this. They have to manually pull it out because it gets stuck in there. Treatment is conservative, sometimes corticosteroid injections, and sometimes surgery. Treatment of acute inflammation and pain includes splinting, which is just putting a brace on it, moist heat, and anti-inflammatory doses of NSAIDs, non-steroidal anti-inflammatory drugs, which are ibuprofen is a classifier for that, as well as Aleve and naproxen, which is also Aleve. I think Motrin too. If these measures fail, injection of a corticosteroid suspension into the flexor tendon sheath along with splinting may provide safe, rapid relief of pain and triggering. Operative release can be done if corticosteroid therapy fails, so operation to release can be done. It says that it is it's a thickening or nodule within the tendon. The thickening or nodule blocks the smooth extension or flexion of the finger. So it could be stuck in extension, can't get into flexion, or flexion, can't get into extension. Okay. So let's do the complete anatomy app. And then that real quick. I'll just make it wider. It is already where we left it. And so we look and see the way these are pennate muscles between them. They're more for like adding the fingers to the midline and abducting from the midline. Which is actually the ulnar nerve or the lower brachial plexus. They call it CAT1. And so we can see all these muscles, the tendinous sheath in there, the arterial supply. Let's look at where they said right by the thumb and index finger. She's having problems at the index finger. This right here is the flexor digitorum superficialis. So that's part of the longer muscle that you can see the tendon is running along here, and it goes over the wrist, and it is going to go into the elbow, the inside elbow, the ulnar side. And then we can look at this muscle. That is the transverse head of adductor pollicis, the adductor pollicis. So it adds the thumb. So this is, so when you have your hand in supine, moving the thumb up and down, like if it's on the table, up and down, that's flexion and extension. Now, if you move it to the pinky and across, you add it to the pinky, you abduct it. So this is the adductor pollicis. This muscle brings the thumb towards the pinky, right there. And then you can look at the other muscles on the thumb. Flexor, this flexes, so it's going to flex it, push the thumb outwards away from the hand. And this is the extensor muscle. Oh, this is the abductor, so it's taking it from the pinky and away from its location, abducting. Abductor, the flexor abductor, I think is ulnar 8 also, and then the adductor, this one. I think these two, adductor pollicis and flexor. No, I think it's the flexor pollicis and the adductor. Those are cranial nerve 8. Oh, not cranial nerve, cervical nerve 8, or the lower lumbar ulnar nerve. So they'll supply that, as well as adduction and abduction of all the fingers from the midline, which is this one of the hand. Let's look at the synovial fluid. So we can't really see it, but under each tendon there's like a bursa, and then each joint, each attachment, there is synovial fluid for that joint to lubricate it between the hyaline end plates. We'll go ahead and let's remove one muscle layer at a time. That was the extensor pollicis. That was the flexor pollicis. This one's the adductor pollicis. Let's see what this muscle is. That one is the opponens pollicis. It opposes the pinky, so it will bring it to the pinky, I guess, or use that, I guess, whenever you're digging into something too. It opposes it. It works with the extensor, which was right next to it, and the flexor right below it, and the adductor right there. Away some more muscle layers. Ligamentous sheath, the common flexor tendon sheath. There will be synovial fluid under this that starts to run out. Osteoarthritis, all these blood nutrient supplies getting blocked by inflammation. Hence, they say in the Merck manual, they can take over-the-counter NSAIDs like ibuprofen, Motrin, Aleve to block the inflammation. That pain is related to inflammation. And then here we have the tendon flexor pollicis longus. Here we can get trigger finger, beak flexor. This tendon can have a depleted synovial fluid bursa sacs region that doesn't allow it to be lubricated. It stays stiff, and it can't, whenever it's in extension or flexion, it stays in that state, and you have to manually pull it to stretch it. Trigger finger, or it could be even this one right here, this synovial sheath. So there's synovial fluid in there in the normal finger to allow it to flex and extend. This is empty of synovial fluid. And so those tendons that go in there, they lack that, they get stiff, they get stuck, and it will be stuck in extension or flexion, the synovial sheath. That can happen in osteoarthritis or someone with diabetes. That's what the Merck manual says. So now you know a little bit more about trigger finger. All right, well, I'm going to stop sharing. That's it for today. You guys have a great rest of your day. I'll see you next time if there is anything that comes up. Or just for my workout. You guys can check in and see my results. Today I was 56 pounds. I started at 161 a week ago. I'm just gradually losing weight and toning up. I can bench press 105. Boom, boom, boom. Gradually do that. You never want to lift more than 5% of a weight that you were lifting. 3 sets of 10 at a comfortable pace and level. Once you get to that level, you can add more weight, but do it no more than 5% or 5% or 5 pounds, one of those, than the other weight, because you never want to risk a tendinous rupture. I did massage this guy. Wasn't a jerk until he became a jerk. And actually I left because he was such a asshole. I decided I don't want to work with these weird ass people. He ruptured his whole pec tendon off because he was trying to be really powerful in the gym. He got his ego ahead of him, and he couldn't lift 3 plates on each side, and his shoulder ruptured off of his bone. I didn't tease him on that, but he said he was diagnosed with type 1 diabetes at a late stage, and that doesn't happen. It does not happen. They never told me this in medical school. It's type 2. So whenever you're always doing stuff that's stressed out, you get gluconeogenesis, and it gets your corticosteroid and your glucose working. Over time, you get more glucose in your body, and that's a lot more work for your pancreas to pump out more insulin. So you may think that just because you're working out and you're stressed and you're burning fat and you're burning calories, that you're going to be free diabetes, but that is not the case, because if you are stressed when you're working out, you risk having more glucose in your bloodstream, and you know what you risk? Cortisol effect, also gaining more weight, because it thinks that it's going to need more energy for next time you decide to get crazy, which will be often, because if you're working out all the time and you're stressed out and you keep doing it because you want that high and that feeling of power and relief afterwards, then you're at risk of diabetes, type 2 diabetes, which can be reversible. So you need to work out at a peaceful pace with an exercise that does not stress you out, okay? That's why we don't try to work out too hard, because I can easily do 30 minutes of boxing. But I'm not going to try and do that, because I will get the cortisol effect, and I will get stressed out, and every little thing will really irritate me. Every little sound, every little beep, every little click, I will take it personally, and that's a sign of stress. Type 1 diabetes, not diagnosed in a late stage. Type 1, you usually know it by puberty, because you may have a little bit of circulating insulin, but then your pancreas just doesn't make it anymore. You are completely insulin dependent on synthetic insulin to keep you alive, keep your limbs attached, and keep your body using up the proper amount of glucose. If you're an older person in your 40s and you've been lifting heavy, requiring a lot of energy and glucose in all your cells, and then all of a sudden you got type 1 diabetes, you were diagnosed with it because you are now insulin dependent on entirely, you got you got misdiagnosed then, okay? Because that just doesn't happen. They didn't tell us that in medical school. They said, nope, that's a young person's disease. They find that out when they're young. They don't make it to a later stage in life and have enough insulin from their pancreas to suddenly drop into type 1 diabetes, unless they've had a severe case of pancreatic cancer or pancreatitis or something like that doesn't make insulin anymore, which he didn't have. So anyways, he pissed me off because I just had to tell him. I had to tell him, dude, you have type 2 diabetes. There is no way it's type 1. And he started arguing with me. I was like, I don't even want to massage you because I see your open wound right there. And like, I can't believe you told me to massage you because we're not even supposed to. Okay, not unless we have gloves on. I did wear gloves. But he was like freshly out of surgery. I know his name. I'm not telling it to you. I know what he looks like. He looks like the typical misogynist. But he dates a powerful, strong woman to prove he's not a misogynist. No. Okay. Yeah. Anyways, that's it for today. We'll see each other next time. Have a good one.